Ever feel like understanding medical tests is like, well, it's trying to crack a code? If you want to be really well informed, especially if you're prepping for exams like the MRCGP AKT, getting these concepts down is just essential.
Absolutely. It's more than just exam fodder, isn't it? Understanding test performance is fundamental for, good clinical decisions.
Right.
And that's why today we're doing a deep dive into one of those key, sometimes slightly tricky concepts, sensitivity. In diagnostic testing, that is.
Exactly. And we're using source material today that's really focused on what every GP should grasp about sensitivity, especially with the AKT exam in mind. Our aim really is to clarify the definition of sensitivity and see how it stacks up against other ways we measure how well a test performs.
Okay, so to get us started, the source material throws a pretty typical exam-style question at us. Ready?
Able to hear.
It asks, in the context of diagnostic testing, which statement best defines the term sensitivity? And we've got 5 options, A through E. A is percentage of individuals without the disease who receive a negative test result. B, the likelihood that a person has the disease if the test result is positive. C, proportion of patients with the disease who receive a positive test result. D, degree to which the odds of disease increase following a positive test. And finally, E, the likelihood that a patient is disease-free if the test result is negative.
Okay. Quite a few options there to sift through, so the question's laid out.
Yeah.
And the answer, according to our source, is C.
Spot on. C, proportion of patients with the disease who receive a positive test result.
Right, so let's really dig into why C is the correct definition of sensitivity.
Okay, so sensitivity, basically, it measures how good a test is at picking up people who do actually have the condition we're testing for.
Right, the true positives.
Exactly. It's the test's ability to correctly identify those true positives. You can think of it as percentage.
Got it. So, like, if a test has 90% sensitivity, what does that mean in practice?
Yeah, good question. The source gives a clear example. Imagine you have 100 people, and you know they all definitely have the disease. A test with 90% sensitivity. It will correctly flag 90 of those 100 people as positive.
Okay, so it finds 90 out of the 100 true cases.
Precisely. That shows you its power.
And I guess that makes it super important for screening tests, doesn't it? Where you really don't want to miss cases early on.
Absolutely. You've hit the nail on the head. Resources like, NACIS and the NHS guidance, they emphasize this. Missing a diagnosis in screening can have really serious implications down the line.
Makes sense.
So a highly sensitive test, it's like casting a wide net. The goal is to catch pretty much everyone who has the condition in that first pass.
That's a good analogy, a wide net. And the source material even gives us a mnemonic, right, to help remember this.
It does. SNOUT. S-N-N-O-U-T.
SNOUT. Okay, what does that stand for?
It means a sensitive test. When negative, helps rule OUT, the disease.
Oh, okay. So if a test is really good at finding the disease, high sensitivity, a negative result gives you more confidence that the person doesn't have it.
Exactly. It's a neat little memory aid.
Okay, so we're pretty clear now on why C defines sensitivity.
Yeah.
But sometimes understanding what something isn't helps just as much. Let's look at the wrong answers. Option A first.
Sure. Option A was percentage of individuals without the disease who receive a negative test result.
Right. What's that then?
Well, that's also really important, but it's not sensitivity. That's specificity.
Specificity, okay.
Yeah. Specificity measures how well a test correctly identifies people who don't have the disease, the true negatives. So sensitivity finds the sick people. Specificity correctly clears the healthy people.
Got it. Sensitivity for true positives, specificity for true negatives. A key distinction. Okay, what about option B? The likelihood that a person has the disease if the test result is positive.
Ah, that one describes the positive predictive value, or PPV.
PPV.
Yeah. PPV tells you, okay, someone's tested positive. What's the actual chance they really have the disease? But, and this is crucial, PTV isn't fixed. It changes based on how common the disease is in the first place, the prevalence.
Right, right. A positive result means something different if it's for a super rare disease versus a really common one. That makes sense. Okay, on to option D. Degree to which the odds of disease increase following a positive test. Sounds a bit more complex.
It is a bit more complex. That's defining the positive likelihood ratio, or LRO.
LRO.
Yep. Likelihood ratios, both positive and negative, they combine sensitivity and specificity into one number. The LRO tells you how much a positive test result increases the odds of someone actually having the disease.
Interesting. So it factors in both true positives and false positives implicitly.
In a way, yes. It gives you a measure of how much that test result shifts the probability.
Okay. And the last one, option E. The likelihood that a patient is disease-free if the test result is negative.
And that one is the negative predictive value, NPV.
NPV, so the flip side of PPV.
Pretty much. It tells you the probability that someone doesn't have the disease, given they got a negative test result. And just like PPV, NPV is also heavily influenced by the disease prevalence in the population being tested.
Okay, wow. So sensitivity, specificity, PPV, NPV, likelihood ratios, they all give us different pieces of the puzzle about how a test performs.
Exactly. You need to understand how they differ and when each is most relevant.
And to really hammer home the concept of sensitivity, the source has this thing called a volt pearl.
Yes, it's a great little takeaway. It says, think of sensitivity as your early warning radar.
Oh, I like that. Radar.
It's not about confirming disease, it's about not missing it. A highly sensitive test casts a wide net, catching nearly all who have the condition. Perfect for screening tests where missing a diagnosis is dangerous.
That radar analogy is really helpful. It captures that idea of detection, of not letting things slip through, even if it means you sometimes get a blip that turns out to be nothing, a false positive.
Precisely. It highlights that primary role, especially in screening. Don't miss it.
So the main thing for you listening to take away is that sensitivity is all about the test's ability to correctly identify people with the disease, the true positives.
And it's critical when the cost of missing a case is high.
And really getting your head around sensitivity, it's not just for exam points, is it?
Yeah.
It's genuinely vital if you want to properly interpret medical results and understand the tools we use every day.
Couldn't agree more. And look, if you are prepping for the MRCGP AKT, or maybe you just want to solidify your understanding of these core stats concepts, then definitely check out mcqvault.co.uk. They've got loads of resources, question banks, video tutorials, study plans, all geared towards helping you master this stuff for the exam and for practice.
That's mcqvault.co.uk. Great resource. So as we wrap up, here's a final thought for you to chew on. How does your understanding of sensitivity versus, say, specificity change how you might interpret test results in different clinical scenarios? Think about the consequences of a false positive versus a false negative in different situations.
That's a really practical question to consider. It forces you to think about the trade-offs. And just a final reminder, the information we've covered today is grounded in guidelines and info from bodies like NICE, the NHS, RCGP, BNF, GMC, RCPCH, and Public Health England.
Loads of reputable sources. You can always dig deeper if you want more detail.